Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. Let's practice applying what we know about Rh incompatibility and ABO incompatibility and how it relates to pregnancy. Question number 1. At 28 weeks gestation, an Rh negative woman receives RhoGAM. Which of the following would indicate that the medication is effective? A. The baby's Rh status changes to Rh negative. B. The mother does not produce Rh antibodies. C. The baby does not produce Rh antibodies. Or D. The mother's Rh status changes to Rh positive. The best choice for this question is B. The mother does not produce Rh antibodies. If we look at the rationale to find out why, we see that RhoGAM is given to an Rh negative mother to prevent her immune system from forming antibodies to Rh positive blood. We don't know at 28 weeks gestation if her baby is Rh positive or Rh negative. And so all moms at 28 weeks that are Rh negative get RhoGAM in order to prevent this antibody response just in case. The effectiveness will be determined by if she doesn't produce the antibodies. And the RhoGAM is used just to prevent antibody formation. It does not change the blood type for the mother or for the baby. Question number 2. Which infant is at the highest risk of being affected by Rh incompatibility? A. The mother is Rh negative and the father is Rh positive. B. The mother is Rh negative and the father is Rh negative. C. The mother is Rh positive and the father is Rh negative. Or D. The mother is Rh positive and the father is also Rh positive. The best answer for this question is A. The mother is Rh negative and the father is Rh positive. And if we look at the rationale for this question, Rh incompatibility occurs if the mother is Rh negative and she carries a fetus who is Rh positive. Two Rh negative parents cannot produce an Rh positive baby. So if we know the mother is Rh negative, in order to have an Rh positive fetus, the father needs to be Rh positive. Question number 3. A client who is Rh negative experiences a spontaneous abortion at 12 weeks gestation. Which nursing action is appropriate? A. Administer RhoGAM within 72 hours. B. Schedule RhoGAM administration at the next prenatal visit. C. Withhold RhoGAM because the pregnancy ended early. Or D. Omit RhoGAM because the fetus was not viable. A is the correct answer to administer RhoGAM within 72 hours. And the reason for this is because that the Rh negative client could be exposed to Rh positive fetal blood and risk isoimmunization even if it was an early pregnancy loss. So we don't know if the baby was Rh positive or Rh negative. And so it's going to be imperative that she receives the RhoGAM. RhoGAM should be administered within 72 hours of an abortion, a miscarriage, or also invasive procedures. Gestational age and fetal viability are not going to affect the need for RhoGAM because she still can produce the antibodies if that baby was Rh positive, and it would affect a future pregnancy. Question number 4. A woman is Rh negative and pregnant. Her previous baby was Rh positive. The nurse would be correct in telling her which of the following information. A. You will receive RhoGAM 4 days after delivery. B. You do not need RhoGAM because your previous baby was Rh positive. C. You will receive RhoGAM at 28 weeks of pregnancy. And D. Your partner is at risk as well as your baby. The best answer is C. You will receive RhoGAM at 28 weeks of pregnancy. So if we look at the rationale for this question, the Rh negative mother who delivers an Rh positive baby must receive RhoGAM within 72 hours to prevent sensitization in future pregnancies. So she will need to receive it with every pregnancy if the baby's Rh is positive. Additionally, anytime a mom is Rh negative, we give that mother RhoGAM at 28 weeks gestation to provide prophylactic protection in case of any bleeding that could occur before delivery that could cause her body to see that positive blood type and build antibodies. And so she will get RhoGAM at 28 weeks, and then they'll test the baby after delivery to determine if she needs RhoGAM at delivery as well. Her partner is not at risk, and her partner does not receive RhoGAM. This is just for her. Question number 5. Who is at risk when Rh incompatibility occurs during pregnancy? A, the mother, B, the father, C, the baby, or D, there is no risk? The answer is C, the baby. So in looking at the rationale, the Rh incompatibility happens if the mom is Rh negative and the baby is Rh positive. If the mother becomes sensitized, she produces antibodies that can cross the placenta. If the antibodies cross the placenta of an Rh positive fetus, it can destroy the red blood cells of the baby and lead to hemolytic disease of the newborn, erythroblastosis fetalis, anemia, jaundice, all sorts of things. And so the mother and the father are not at risk for harm here. It's the baby that is at risk. Question number 6. A postpartum client's blood type is A negative, and her newborn's blood type is AB negative. The client receives RhoGAM at 28 weeks gestation and again in the 3rd trimester after a minor car accident. As the client prepares for discharge, she asks when she will receive her next dose of RhoGAM. Which response by the nurse is most appropriate? A, you already received 2 doses of RhoGAM during your pregnancy and do not need an additional dose. B, I will give you your last dose of RhoGAM today before you go home. C, both you and your baby have negative blood types, so another dose is not needed. Or D, RhoGAM is routinely given during delivery, so you already received it. C is the best answer to this question. Both you and your baby have negative blood types, so another dose is not needed. So when we look at the rationale for this question, RhoGAM is only required if the Rh negative mother delivers an Rh positive baby. This mother and this baby are both Rh negative, so no postpartum dose is indicated for her. She got RhoGAM at 28 weeks, which is routine, and then she also got it after trauma, which is appropriate as a preventative measure. The number of doses is not dependent for the pregnancy that you only get 2. It just is dependent on the need. And so she had a need when she had the car accident. She does not have a need for RhoGAM now because her baby is Rh negative. This is solely going to be dependent on the status of the baby, if they're Rh positive or Rh negative at delivery. Question number 7. Which condition is most likely to occur when a mother's blood type is O and the baby's blood type is A or B? A, erythroblastosis fetalis. B, Rh incompatibility. C, vitamin K deficiency bleeding. Or D, ABO incompatibility. For this question, the best answer is D, ABO incompatibility. So if we look at the rationale for this question, ABO incompatibility occurs when the type O mother carries a fetus that has type A or type B blood. And so the mother can have antibodies that are already pre-existing to the A or the B antigen. And if that's the case, then this can affect the current pregnancy because these antibodies can cross the placenta and cause hemolysis to the fetal red blood cells of the current pregnancy and lead to newborn jaundice. Question number 7, continued. Erythroblastosis fetalis is what option A was. And this is something that is more commonly seen with Rh incompatibility. So Rh incompatibility is going to have, if the mother didn't receive RhoGAM, there's a much larger immune response and a larger amount of antibodies that can be breaking down the baby's red blood cells. And so the effects to the baby is much more significant. So erythroblastosis fetalis is not commonly seen with ABO incompatibility. B option was related to Rh incompatibility, and so that's going to be completely dependent on Rh factor, not ABO. And then the option C, vitamin K deficiency bleeding, is unrelated to maternal fetal blood type differences. Question number 8. A nurse is caring for a newborn who is 4 hours old. The mother's blood type is O positive and the father's blood type is B positive. Which condition should the nurse most closely assess the newborn for? A. Hypoglycemia, B. Hyperbilirubinemia, C. Neonatal abstinence syndrome, or D. Positive indirect Coombs test. So B is the correct answer, hyperbilirubinemia. So let's look at that rationale. If the mother's blood type is O and the baby is anything other than O, then she can have pre-existing antibodies that could destroy the baby's red blood cells if it doesn't recognize those antigens. Okay, so if the baby is A or baby is B. In this case, the father is B, so there's a possibility that the baby could be B, which puts the baby at risk of ABO incompatibility, and then that can release bilirubin when the red blood cells are broken down and cause jaundice, hyperbilirubinemia and jaundice. One of the options for this was related to the Coombs test. The Coombs test can determine if the mother has the antibodies. If you do an indirect Coombs test, it looks for those antibodies. And then a direct Coombs test is done on the baby's blood after they're born to see if there are maternal antibodies on the baby's red blood cells. So that is how we could also determine with a direct Coombs test if the baby is at risk of developing hyperbilirubinemia if those antibodies are on the red blood cells. Question number 9. A nurse in the newborn nursery is monitoring an infant for jaundice related to ABO incompatibility. What blood type must the mother have to cause this incompatibility? A, B, AB, or O? So for this question, the answer is O, which is option D. And if we look at the rationale, we're reminded that ABO incompatibility most commonly occurs if mom's blood type is O and she's carrying a baby with type A or type B blood. Type O mothers can have pre-existing anti-A or anti-B antibodies that can cross the placenta and cause hemolysis. If the baby's blood type is A or B, then this is going to be the concern. It can cause newborn jaundice. And then question number 10. A mother with type O blood delivers a newborn with type A blood. Which complication is most likely to occur and what is the priority nursing action? A. Rh incompatibility, administer RhoGAM. B. ABO incompatibility, monitor infant for hyperbilirubinemia. C. Rh incompatibility, administer vitamin K. Or D. ABO incompatibility, provide phototherapy. The best answer for this is B, ABO incompatibility, and monitor the infant for hyperbilirubinemia. So in this scenario, the mother's blood type is O, okay, and the baby's blood type was A. Maternal antibodies may be present to the A antigen that could attack and destroy the baby's red blood cells, releasing bilirubin. So the risk for hyperbilirubinemia is increased with ABO incompatibility, and so the initial priority is going to be to monitor for symptoms of hyperbilirubinemia. It is possible if the baby develops hyperbilirubinemia that they will require phototherapy, but we need to first monitor for the symptoms and monitor the levels to know if that's even a needed intervention. So RhoGAM is related to the Rh incompatibility, not ABO, and vitamin K prevents bleeding disorders, not hemolysis. So those are the other answers that were not correct. So as we recap, Rh incompatibility, the mother's blood type is Rh negative and the baby's blood type is Rh positive. There can be antibodies that would affect a future baby if we did not treat with RhoGAM. So RhoGAM is going to prevent this antibody response. It is not going to affect the first pregnancy because the antibodies haven't had an opportunity to be established at this point because the body hasn't yet seen that Rh positive blood type. And it can have more serious effects on the newborn than the ABO incompatibility can. With ABO incompatibility, the mother's blood type is O and the baby's blood type is anything else, A or B. The antibodies could affect the current baby because these antibodies are pre-existing. RhoGAM is not going to help prevent the antibodies because the antibodies exist for other reasons. So it can affect the first pregnancy. And in this case, it can lead to jaundice for the baby. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.